Okay, the week that assigned to present it is a week 14 for imaging and processing in radiation oncology. Let's get started. The first section of the week 14 is the benefit of CT simulation or the advantage of CT simulation. We just started with the 3D delineation of the 3D volumes in treatment position, ability to outline the tumor or organ at the risk or OAR. Quick, accurate isocenter placement. I'm going to explain each one next slides too. More data for post-simulation calculation, virtual simulation, boost field planned without patient present, PEV able to be viewed, field shaping electronically, comparing to before they were using a block and they have to shape the block and they put it on the linear accelerator. Now they don't do that. Just they change the shape on the computers. Here is more advantage of the CT simulation. The DRR, construction without patient present, which is DRR stands for digital reconstructed radiograph, which is help to monitor the patient setup during the treatment, which is image guidance system, ability to view the dose distribution, ability to view the intrafraction movement, which is the setup of the patient, 4D display, reduction in the procedure time, digital archive, CD exposure able to be quantified. Okay, on the first slide I was explaining that BEV able to be viewed, which is what that means, which is beam eyes view. If we see over here, it's already this is the shape, this is the beams, and if you see over here there is a shape as a circle over here, just to protect the eye from cataract, which is doesn't receive any dose. And if we see over here there is already shaping. This is the beneficial of the CT simulation now. First slides I was explaining the 3D delineation and the volumes, which is that's a benefit of the CT simulation. Now here I'll try to explain the 3D images definitions or 3D image advantage or function, which is help to precisely define the target and those enable to precise and accurate treatment planning with the shape, beam in isocentric or non-isocentric geometry, which is try to present the GTV and the CTV and or ITV or PTV, which is gross tumor volume, which is if we see over here, it's already shaped for us. Which is try to find the organ at the risk. And also the 3D image dataset square simulation is the snapshot of the normal structure and the patient shape and the position at the single time point. And it's a model that is used for the plan development and the dose calculation, which is we know that each organ has a different radio sensitivity and radio resistance. By that we can the radiation oncologists can provide the correct dose level to give or the tolerance dose to the patient. The 3D image that help align the target to correct for interfractional errors, which is what that means, which is the patient, which is the change the motion, which is an interfraction motion, which is change in the position from one fraction to the next, which can be the setup of the patient too. Okay, here's some questions from Week 14 review, which is image techniques that are used to define the target and able to precise and accurate treatment planning, which is cone beam CBCT scan, magnetic resonance imaging, which is MRI, positron emission tomography, which is PET, and the 3D structure and biological information. These are the 4 techniques that are used to define the target and able to precise and accurate treatment planning. Here are another questions for week 14 review, which is imaging techniques that are used in a room to obtain periodic information on target position and movement, which is that's in a room, will be planners, volumetric, and video or ultrasound based. Volumetric will be 3D, planners can be IGRT, and ultrasound too. Here is a part of the CT simulation concentration, which is for week 14 lectures, which is the CT simulation concentration include aperture must be large enough, scan field must be large enough, couch must be flat and level, external marking system time should be short as possible. I'm going to explain why for each one. So first, aperture must be large enough to accommodate patient immobilization device. Scan field must be large enough to view the entire patient contour. Couch must be flat and level for accurate reproducibility and perpendicular to the CT bore. And the external marking system is just to localize the isocenter. Time should be short as possible to reduce possibility of the patient movement. Okay, here's the last two of the CT simulation concentration, which is interfraction variability reduce. What that mean, which is we know the interfraction motion, which is change in position from one fraction to the next, which is try to reduce the movement, which is by that can by ensuring that and make sure that the patient feel comfortable to during the treatment. Monitor the CT dose too. This slide, I'll try to present the three definitions by these pictures, which is really helpful to understand the definitions such as the CA, which is the central axis, the intrafield distance, and the isocenter. I found this picture is the Washington Lever book. Okay, so let's start. The CA will be, or CAX, which is the central axis, which is a line perpendicular to the cross section of the treatment field, which is this one. And the IFD, which is intrafield distance, which is the distance from here to here, will be the measurement to determine the thickness of the body part from the entrance to the exit point at the central axis. The last one will be the isocenter, will be this one. So the point in the space where the beams interrest. Okay. Here are the definitions that I already presented in the previous slides, which are the CA, or the central axis, which is line perpendicular to the cross section of the treatment field. Intrafield distance, or IFD, which is measurement to determine thickness of the body part from the entrance to the exit point at the central axis. Isocenters, which is the point in space where the beams intersect. Okay, here are some terms that we have in week 14 also, which is SAD, which is source axis distance, which is source of radiation to the isocenter. SAD is the same as the isocenter. TID, which is target image receptor distance. SSD, which is source to the skin distance, which is the distance between radiation source to the skin surface. And source focal spot, which is geometric point where the radiation beams emerge. Okay, simulation procedures. One of them is communication, the other one education. One of the main points that radiation therapists must follow during the simulation is communication to reduce the anxiety during the treatment or during the simulation. By that, we such as understandable, explain, illustrate, present anything they want to make them feel more comfort. Establish environment where communication is facilitated clearly and effectively. Miscommunication can lead to major effect on patient care. Explain the procedures in effective manner based on upon nonverbal cues given by the patient. Gauge the patient need, want for abdomen teaching. Use appreciate level of the patient understanding just to make sure that the patient feel more comfort by have this kind of communication. Here another part of the simulation procedures will be education, which is try to speak slowly, clearly, and the patient more comfortable with the family at the simulation. Try to accommodate, explain the equipment, procedure, follow-up instruction. Why we have to do that? Because we see one of the question in the lab when they said the most common question they ask, why I have to do CT simulation. I already have done that before. Just try to explain that CT simulation is not only for diagnostic, but it's also to find the plan treatment that you will use during your treatment, which is by that the patient feel more comfort by understanding why we do another CT during the simulation. Okay, here another questions for week 14 reviews. For external beam radiotherapy techniques used to help reduce the safety margin around the target volumes are IMRT, which is intensity modulated radiation therapy, VMAT, which is volumetric modulated arc therapy, SRS, which is stereostatic radiosurgery, and SRT, which is stereostatic radiotherapy. Okay, here another question for week 14 reviews. To ensure that all the internal movement does not compromise dose delivery to the CTV, what is taken use? So they are using wider PTV margin are taken. This causes a large volume of the normal tissue to be included in the irritated volume. Okay, here another question. What does IGRT stand for, which is image guided radiation therapy? I have the last questions for this presentation is give one advantage and one disadvantage of KVCT in the cone beam or CBCT. So the advantage of the KVCT is gives better contrast resolution compared to the MVCT. The disadvantage of the KVCT is limited by artifacts from prostheses and scatter from the bulky patient anatomy.